Good afternoon, everybody. Thanks for joining us today in our general surgery grand rounds. Welcome, Danielle Bear, and thank you for joining us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you to our moderator for this event, Dr. Felipe Casas, General Surgeon and Nutritional Support Leader at La Cardio. Welcome, and thank you for moderating this event. Adelante, Dr. Felipe.
Gracias. Buenas tardes a todos. Mi nombre es Felipe Casas. Muchas gracias, Lorena, por la introducción y muchas gracias a todos por su participación. Les recordamos que al conectarse a esta conferencia, autorizan el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 de 2012 y nuestra política de datos personales, la cual pueden consultar en www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada. En el chat de preguntas, pues va a estar habilitado la barra de participantes por si quieren dejar ahí sus inquietudes. Un agradecimiento muy especial para AOR por vincularse como un patrocinador exclusivo de esta actividad. Y hoy tenemos el honor de contar con la expositora Danielle Bear con la conferencia Is there an optimal nutritional support in patients undergoing ECMO? Danielle es una nutricionista dietética de la Universidad de Wollongong. Trabajó un tiempo en Sydney y actualmente trabaja en Londres, donde es la nutricionista principal de la unidad de cuidados intensivos en el Guy and St. Thomas Foundation Trust desde más o menos hace 11 años. Asimismo, Danielle completó recientemente un doctorado en educación clínica y se ha enfocado más que todo en la medición y prevención del desgaste del músculo esquelético durante la enfermedad crítica y el efecto de este en la recuperación. Asimismo, también cuenta con una gran cantidad de artículos publicados en las principales revistas de cuidado crítico y soporte nutricional. Además, ha recibido el prestigioso premio de Ross Simons de la Asociación Dietética Británica por sus trabajos en investigación y ha sido parte fundamental en la orientación de los cuidados nutricionales en las unidades de cuidado intensivo durante la pandemia del COVID-19 y se encuentra actualmente en el cuadro de honor de la Asociación Dietética Británica por sus trabajos en el 2020 y en el 2021. Danielle, welcome. You may start with your conference.
Lovely, thank you so much. I'm just going to share my screen with you and you can let me know if that's okay. Is someone able to allow me to share my screen? It's just disabled for me at the minute, thank you.
1 second.
Thank you.
Mile, por favor, puedes... no, un segundo. Okay, so
great, thank you so much. Okay. That's perfect, thank you.
I think you can now.
Yes, I can, that's right. Okay. All right, can you see my slides okay?
Yeah, it's okay.
Wonderful. Okay, so thank you so much, Felipe, for the invitation to present today. And thank you to everyone for being here. I know that you're really busy at the moment, so I appreciate you taking the time out. And so I was asked to give a presentation on nutrition support in patients receiving ECMO. And this just happens to be one of my specialist areas of interest for research. So I can present to you some of the data that we've been working on. So I work at Guy's and St Thomas's, which is a large teaching hospital in London. And we are one of the 5 severe respiratory failure centres in the United Kingdom. So at the moment, we see around 215 or 220 ECMO patients per year. So we do see quite a few patients, and that's enabled us to really kind of look into their nutritional needs. So I'll share that with you today. So I think like all aspects of critical care nutrition, there are probably more questions than answers when it comes to knowing how to feed this particular group of patients. And this is reflected in the very limited guidance that we have from 2 international guidelines. So for example, in the Euro-ELSO guidance, there is only 1 line at the minute on nutrition that says, as with all critically ill patients, full caloric and protein nutritional support is essential. Now, that's not really very descriptive, and it doesn't really give us a very good idea of how we should feed these patients. And at the moment, we are actually writing a specific guideline on behalf of EuroELSO that will give a little bit more direction into what we should be doing with this group of patients. There is another guideline that has one recommendation for how to feed ECMO patients, and that is the ESICM clinical practice guidance around early enteral nutrition. And they suggest using early enteral nutrition in adult patients receiving ECMO. However, given the very limited evidence that we have, this recommendation is only based on expert opinion. So a few years ago, we reviewed the evidence around nutrition support in adult patients receiving ECMO. And I can tell you that at that time, this was in 2018, there were only 7 observational studies that looked at anything to do with nutrition support in ECMO. So there were very few studies. At the moment, there's probably around 12 or 13, but they are all still observational studies. So what I thought I would do today is take you through some of the evidence around particular topics. So I want to cover the importance of nutrition support in this group of patients, the timing and the route of nutrition support, the dose of nutrition support, and then also barriers to the delivery of enteral nutrition and how we in our unit get over some of those barriers. And then I want to leave some time for questions so that you can ask me anything specific around the practicalities. So I want to take you through some evidence and then some kind of practical recommendations based on our clinical practice and not necessarily evidence-based. So I will start with the importance of nutrition support. And this is something that I think is really important to me as a dietitian. And I think that enough emphasis isn't really put on this. And that is that not every patient is the same, and one size doesn't fit all. So there really needs to be quite a lot of individualization that goes into the nutrition plans that we give to these patients. And if I give you some examples, we can see the types of patients that we might have receiving ECMO. So, for example, there's this type of patient here. This gentleman was on ECMO for 3 weeks. And you can see from the picture, he's incredibly weak. He's so weak, he actually can't even close his mouth. He has a tracheostomy and he still requires NG feeding at this point in time. He is very different to this type of patient that we also see. This is a young lady, again, who had a very long ECMO run, but is able to sit up. She can get out of bed. She's able to participate in more rehabilitation. So she was watching television and she was playing some computer games as part of her rehabilitation. So she's a very different patient to the first one that I showed you. And then we also have this type of patient here who, again, has a tracheostomy, still requires some ventilation from the mechanical ventilator, is on ECMO, but is also able to participate in quite a lot of active rehabilitation. So he's able to get up and walk. So each of these 3 types of patients do require very different nutrition plans. And I think it's really important that we make sure that we consider that. Now, in critical care, one of the ways that we try and determine how patients should be fed and whether or not they're at high nutrition risk is by using these nutrition risk scoring systems. Now, the most common ones are the Nutrix score. So if you have a score of more than 5, you're classified at high nutrition risk, or the NRS 2002 score. And if you have a score of more than 3, then you're considered to be at high risk. And they all include variables such as age, body mass index, the severity of illness, admission category, length of stay in hospital prior to ICU, and potentially number of comorbidities. Now, unfortunately, if we used these scoring systems for our ECMO patients, they generally come out as scoring at very low nutrition risk. And that's because they tend to have a lower age, because we don't tend to put patients on ECMO who are in the older age category. the severity illness scores that we use, such as the Apache score or the SOFA score, generally come out much lower than someone who's not on ECMO, but that isn't a reflection of their severity of illness. And we also know that they will come out much lower in the scoring because they have fewer comorbidities than the general ICU population, because we wouldn't necessarily choose to put someone on ECMO if they had a large number of comorbidities. So this really skews these scoring systems. And in my view, in ECMO patients, we shouldn't really use a scoring system, but we should consider each of these factors in turn. So I would suggest that patients who receive ECMO are at high nutrition risk, despite what the scores say, because we know that they are some of the sickest patients that we have on the ICU. We know that they have sometimes a hospital admission or an ICU admission before they even start ECMO. So even though it may be day one for them on ECMO, it might not necessarily be their ICU day one. And we know that they go on to have a prolonged ICU and hospital admission. And all of those factors together put them at high nutrition risk. We also know that these patients lose muscle in the same way that our general ICU patients do. And this was something that I studied recently as part of my PhD. And I wanted to look at the effect of patients who come on to ECMO who have low skeletal muscle mass, and also if those patients lose muscle at the same rate as the general ICU population. So within this study, what we did is do a retrospective observational study. It's recently published in Critical Care Medicine. A retrospective observational study of around 215 ECMO patients that we'd seen over the course from 2011 up until 2016. Sorry about that. And they had to have been receiving ECMO for a minimum of 72 hours and have had a CT scan at their admission to ICU, because that allows us to then go on to measure their skeletal muscle area, which is the red that you can see in this CT scan on the right-hand side here. So what we found was that in the total population, just over 20% of these patients had low skeletal muscle index at the commencement of ECMO. So that's nearly a quarter of these patients who are generally young when they start ECMO. So this was quite a surprising finding for us. And we found that males were more likely to have low skeletal muscle index than females. So this information together suggests to me that if a patient comes in on ECMO and they are likely to have low skeletal muscle index, again, that reflects their nutrition risk. We also found that patients who had low skeletal muscle index at the commencement of ECMO had a longer duration of ECMO. So they had a longer ECMO run by around 4 days. And this was statistically significant. So this is really a very important point, and this is something I think that needs exploring in a randomized controlled trial as to whether or not these particular patients who do have low skeletal muscle on admission, do they need a different feeding regimen to those who don't? I then took a proportion of those patients who had a second CT scan over the duration of their ICU stay, and there were 54 patients, and the median duration between the two CT scans was 9 days. And we found that there was a significant reduction in skeletal muscle area, so around the level of the L3, and that was around 18, and a loss of 18%. So a significant amount of muscle to be losing over quite a short period of time. Now, there are other data from Australia. This is from Kate Hayes and her group in Melbourne, who also see a vast number of ECMO patients. And they measured muscle loss using muscle ultrasound, rectus femoris cross-sectional area, up to day 20 of ICU admission. And again, they found that muscle loss was significant. So around 19% by day 10 and 30% by day 20. So there's a significant amount of muscle loss in these patients. So to add on to the other factors that I already mentioned as to reasons why these patients are at high nutrition risk, they also have low muscle mass on commencement of ECMO and do experience a rapid loss of muscle. Now, despite these factors, we know that underfeeding in the ECMO population is very common. So the data that we have from the observational studies suggests that patients meet only 55 to 90% of their energy and protein targets. So we wanted to explore this in a bit more detail. And again, we looked at around 230 of our ECMO population retrospectively to see how we fit within this 55 to 90% category. And we found that it is possible to meet more than 90% of patients' energy and protein delivery over the course of their ECMO run. So we meet a median of 90% energy and about 85% protein, so slightly lower. And on the whole, that looks pretty good. However, when we drilled down a little bit further, we did find that actually only 41% received adequate feeding of both energy and protein. And we defined adequate feeding of being more than 80% of their prescribed requirements. So actually, it looks like we do well, but less than 50% actually meet their energy and protein targets over that course. So there's a lot of work to do to make sure that we do meet the targets of these patients. Now, one of the reasons, or there are several reasons really that they don't meet these requirements. And the most common one is due to interruptions to enteral feeding. And these are very common. And we found in our population that 91% had at least one feeding interruption during their ECMO run, and nearly 50% had more than two. And the median duration of those feeding interruptions was 9 hours. So if this happens more than once over the course of that ECMO run, you can see how it's really, really easy to underfeed these patients. Now, when we look at the observational data that are available, most studies will cite a high gastric residual volume or poor GI tolerance as the main reason for those feeding interruptions. But actually, we found that it was procedures, and that accounted for 40% of the patients who had these feeding interruptions. And gastric residual volumes really didn't account for that much in our population. But I think that's because we use a lot of NJ feeding and post-pyloric feeding, and we place those at the bedside. And I'll talk to you in more detail about that coming on when I talk about the barriers to feeding. So the most common reasons for us, procedures, but the most common reasons for the other reported studies are high gastric residual volumes. So the question is really, what should we be doing? And as I mentioned at the beginning, there's very limited evidence. And in fact, there are no randomized controlled trials that are investigating any topic of nutrition support in ECMO patients. So we're really stuck with using guidance for the general ICU population, even though we think these patients might be slightly different. And we're stuck with expert opinion based on observational studies. So I'll take you through some of the evidence that is out there, and then also some of the things that we do within our unit. So I want to start with the timing and route of nutrition support. And as I mentioned earlier, there is this suggestion from ESICM that early enteral nutrition should be given to patients receiving ECMO. Now, when we look at the data around this, there are only 3 studies, again, retrospective observational studies, that have looked at any outcome related to the timing of nutrition support. And we have to be careful when we critique these studies, because the definition of early feeding might be different across all of those studies. And it's possible also that there's a difference between patients who receive VV ECMO and feeding in patients who receive VA ECMO. So the first of the studies is quite recent. It was only published this year, and it was a study looking at a retrospective study looking at 60 patients who survived more than 48 hours of ECMO. And in this population, more than 70% were receiving VA ECMO. And they found that early enteral nutrition, defined as enteral nutrition that is started within 48 hours of admission to the ICU, was associated with a decrease in hospital mortality. However, when looking at the details of this study, it's very important to see that actually most participants on this particular unit actually start parenteral nutrition on day 1, and they don't start enteral nutrition until kind of days 2 and 3, and that's their common practice. And less than 50% actually received that early enteral nutrition. So we just need to be careful with, I guess, the using the results from this study when comparing them to your own population, depending on what you would normally do with your feeding practices in your ICU, and also what your ratio of VV to VA ECMO patients is. In the second study is also a large retrospective observational study that ended up analyzing 220 patients who received early enteral nutrition. Again, this was within 48 hours of the start of ECMO, and these were patients who had cardiogenic or obstructive shock and also required VA ECMO. So this didn't include VV ECMO patients. And they also found that early enteral nutrition was associated with a lower in-hospital mortality and also a lower 28-day mortality. And the final study, again, is one looking at the outcomes associated with delaying enteral nutrition after cardiac arrest in patients who were treated with ECPR, so VA ECMO, and also targeted temperature management. This is 140 patients, and early enteral nutrition was also defined as being started within 48 hours. And they actually found that delayed enteral nutrition, so starting after that 48-hour period, was associated with an increased odds of neurologically favorable survival. And that was their primary outcome. And they defined neurologically favorable survival as a cerebral performance category score of 1 to 2. So 3 very different studies, all retrospective observational, and mostly in patients who are receiving VA ECMO. So we don't know a lot about the patients who receive VB. And in my discussions with different ECMO centers, it would seem that there is quite a lot of reluctance to start enteral nutrition in patients on VA ECMO, possibly because they're in shock and the doses of inotropes and potentially vasopressors that the patients are receiving. So I do like to refer back to the Nutria 2 study, even though this wasn't specifically in patients on VA ECMO. It is in patients who are shocked and receiving high-dose vasopressors, and they looked at early enteral versus early parenteral nutrition, and they found that there was no difference in the primary outcome of 28-day mortality, but there was a higher incidence of bowel ischemia in patients who were enterally fed, although the numbers are small and it is a secondary outcome. But my recommendation based on this is that enteral feeding, early enteral feeding is safe in both VA and VV patients, but there might be that you need to take a little bit more care in patients who are on VV, and you might start a little bit slower. So some people might think that starting early enteral nutrition in either group of patients is quite difficult, but we found actually that is very achievable, and more than 95% of our patients received nutrition support within 48 hours, and the median time to starting nutrition support was 13.5 hours. So it's certainly achievable and appears at this point in time to be safe, although that is based on observational data. So our personal practice is to start enteral nutrition early. Normally that would be via an NG tube, unless there is any indication at all to start post-pyloric feeding, in which case we would do that. So what about parenteral nutrition? Because this also comes up as a question and perhaps a controversy as well, because there are lots of discussions around whether or not parenteral nutrition is safe in patients on ECMO, because there's the potential of the lipids to block the membrane. And I can tell you that we probably have around 10% of our ECMO patients who require PN at some point during their ECMO run. And we do always start with a lipid-based parenteral nutrition, and we haven't seen any issues with the membrane being blocked. We do also use propofol, but I will tell you what we use with our cutoffs. And I think the decision to use parenteral nutrition in the ECMO patient has to be based on a case-by-case basis. And the way that we base that is, what is the nutrition risk? So is the patient malnourished, and are they likely to remain on PN for a prolonged duration of time? If it's 1 or 2 days, we might not worry about it, but if it looks like it's going to be longer, then we definitely would. And our consultants like to use a cutoff of a triglyceride level of 3 millimoles per liter to indicate whether or not we would transition that patient onto a lipid-free parenteral nutrition solution. So that is not based on any evidence, and it's certainly not based on any adverse events that we have seen. It is just simply an arbitrary level that our consultants felt that they were happy with, that might reduce the risk of any incidents. So we do daily triglyceride levels, and if it gets to 3 or above, then we would transition that patient onto a lipid-free parenteral nutrition solution. But we do try and aim to put lipid back in the bag once per week, just to make sure we don't develop any essential fatty acid deficiencies, especially if the patient's going to be on longer term. And we would also consider whether or not they're also receiving propofol, because sometimes the lipid dose from the PN plus the propofol can be quite high. So we might need to adjust our PN solutions based on the propofol dose. So that's the root of nutrition support. And then the next part of the discussion is, well, we know the root, but how much do we actually feed the patients? And again, like the wider critical care population, this is always up for debate. And we know that measuring energy expenditure would be the gold standard if that was something that was easy to do. This is a picture here of my very, very old Delta Track that I haven't used in many years because it's not made anymore and you can't have it serviced. But there are definitely newer models of indirect calorimeter on the market that that could potentially be used for patients on ECMO. And there are 2 studies that have provided 2 different methods of measuring energy expenditure. So the first one from Elizabeth de Varley and her group in Belgium, where they do a 2-step process of first connecting the indirect calorimeter to the ECMO circuit via an in-house adapter that they had made. So it's not something that's freely available. And then they hook the indirect calorimeter up to the ventilator. So they then get the energy expenditure from the native lung and then from the ECMO circuit and add them together. So that's one method that has been proposed. The second method is from Tobias Wollersheim and his group in Germany, where they just measure the energy expenditure from the native lung, so from the ventilator, and then they do take the blood gases from the circuit, so the pre and post oxygenated gases, and then they put both of those into an equation. And this is a method that we have tried in our ECMO patients, but I will say that it's not simple. And as things stand, because we don't really know whether there's a benefit to feeding to measured energy expenditure, I'm not sure at the moment that the benefit of that is worth it, considering the time it takes to get a measurement. And you would really want repeated measurements in your patients, because one measurement just won't be enough because your energy expenditure changes over time. So what we're left with is equations to use. And the most commonly used one, and certainly the one that we use in our ECMO population, is 20 to 25 calories per kilo. So we might start at 20 during the early ECMO phase and then go up to 25. Sometimes we go up to 30 calories per kilo if it's a patient who is rehabilitating and walking and doing some more active mobility. We would try and weigh the patients as much as we can, because the downside of using an equation like this is that you might calculate that at the start of their ECMO run, and if you never weigh them again, then that number never changes. So I think we need to just be very careful when using that and make sure that we're monitoring, and we would adjust it for patients who have a higher BMI. Now, in terms of protein, we would aim for a minimum of 1.2 grams per kilo per day for just your average ECMO patient, maybe single organ failure. For patients who are on continuous renal replacement therapy, who are obese, who might have some trauma, who might be a surgical patient, we might add more. So for those on continuous renal replacement therapy, we would aim for 1.5 to 1.7. For an obese patient and a surgical patient, we would aim for 1.5 grams per kilo per day. But again, we might take into account any weight changes that we see along the way for those patients and adjust it. But it does need quite a lot of clinical judgment because, of course, we don't really have a very good way of measuring these requirements at the moment. So as I mentioned before, underfeeding is very common. And similar to the root of nutrition support, there are very few studies that have looked at the effect of underfeeding. So the question is, if you underfeed these ECMO patients, well, does it really matter? Does it affect their outcome? And I think the answer to that at the moment would be, we don't really know. But my gut feeling is that for the patients who are in ICU for a longer period of time, they are going to have better outcomes the better fed they are. And that outcome is unlikely to be mortality, but it is likely to be something along the lines of a reduction in muscle wasting or an improvement in functional ability. But those studies have not yet been done. So in terms of the studies that have explored it, again, they are the retrospective observational studies. There's only one study that has shown a positive association between the adequacy of energy and protein and outcome, and that is the study by Park et al. From last year that showed that patients who received adequate energy intake in their second week of ECMO had a reduction in their improvement in their 90-day mortality. But all of the other studies that have looked at associations between the adequacy of energy and protein show no association. And in my view, I think that's unsurprising. And some of these outcomes, like looking at mortality or length of stay, I think are probably the wrong outcomes to be looking at. And most of these studies are quite small. So I think realistically, we don't know the answer to the question anymore. And at the moment, I would err on the side of trying to make sure that we are adequately feeding the patients, because I think down the line, it's going to have a better outcome for their muscle mass and also their functional ability. So moving on to really the last point that I want to talk about, which is how do we overcome these barriers to the poor delivery of enteral nutrition? And I think it's no different in the ECMO population to the normal ICU population. And one of the strategies that we have found really helpful is the use of the bedside placement of post-pyloric feeding tubes. And we do this using the CoreTrack machine. And this is just an image here showing what the CoreTrack image looks like once you've placed a post-pyloric feeding tube. And all of our ECMO nurses, plus myself, are trained to insert these tubes at the bedside. So if a patient is showing signs of persistent GI intolerance, we would just automatically place the tube at the bedside. Or if they come to us from another hospital and we already know that they have GI intolerance, we would place that tube from the minute they come to us. And as I said earlier, I think that the fact that we place so many of these post-pyloric feeding tubes in the ECMO population quite proactively is probably a reason why we don't find GI intolerance a barrier for us, because we overcome it with the placement of these tubes. So in this population of patients from this study here, it was 37 patients with 40 placements, and over 3/4 of those patients were on ECMO, because that's where we see the biggest need for our post-pyloric feeding tubes. And the CoreTrack isn't 100% successful. It does require a little bit of patience and skill, but we find that it's just under 90% successful, but it's very operator dependent. And the more you use it, the more likely you are to be successful with those placements. And we also very much like using CoreTrack because you can avoid those placements of the feeding tubes into the lung. And then in this particular case series, we saw that 5 lung placements were avoided, which is really good for us because our hospitals get fined quite a lot of money if we place an NG tube into the lung and we feed. So for us, this is a good strategy for 2 reasons. So other strategies that we use are prokinetics. And so our cutoff for what we would call a high gastric residual volume is 300 mils. So on the second aspirate of 300 mils, we would start prokinetics. So I think that would probably be similar to what you would do. We do metoclopramide first. If that fails, we would bring in erythromycin. We have a specific guideline for stopping and starting enteral nutrition. So that gives guidance for stopping prior to extubation and tracheostomies and different procedures and different surgeries. And that helps us to cut down on the time of those feeding interruptions. And that's really important for us. And also the use of parenteral nutrition. So we probably do use parenteral nutrition quite early compared to a lot of other centers. And we don't mind that. We don't see that as a risk. And we don't tend to use supplemental parenteral nutrition very often. We might run a little bit of trophic feeding, but we find that we normally, if we need parenteral nutrition, it's normally total parenteral nutrition. We don't often have patients who receive both unless they're in that weaning phase. So they're the strategies that we use to try and manage some of those barriers. Now, the last point before I finish that I want to make is what some of the studies have shown, including ours, is that patients who are on ECMO are actually fed much better than those who are not on ECMO. And once the patient stops ECMO, they're fed worse than they were when they were on ECMO. So there seems to be a little bit more attention paid to feeding for a patient on ECMO than afterwards. And I think what is really, really important if we want to see these better outcomes for our patients is that we need to include the whole pathway. And we need to make sure that the nutrition care of those patients doesn't stop when they leave the ICU. We also have to make sure that they're getting good nutrition care when they leave ICU and step down to the ward, and also when they go back home as well. And we bring our ECMO patients back into a follow-up clinic, and it's always really nice to see how well they're doing because the outcomes tend to be quite good. But it's also a chance for us to catch up with them and see how they're doing nutritionally. And interestingly, what we tend to see is that the patients will lose a lot of muscle when they are in the ICU and when they're in hospital, and then they go back home and they're quite immobile. And so their weight gain is actually very rapid, but it tends to be a lot of fat mass rather than muscle mass. So that's something that we need to work on in terms of research and see, what's really happening and how we might be able to hold on to a bit more of that muscle mass and start to rebuild that once the patients are more mobile. So this pathway is really, really important. So in conclusion, I think nutrition support is an incredibly important component of the treatment of patients receiving ECMO, both VA and VV. And that's particularly because around 25% of them have low muscle mass when they start, and muscle wasting is significant. So strategies to optimize nutrition delivery should be used, and early enteral nutrition is possible and certainly recommended, but there might need to be a little bit of care in ECMO and VA ECMO patients, but it's still something that we should be doing as a standard of care. So thank you so much for listening to me. I will stop sharing my screen, and I'm really happy to take any questions that you might have on anything you wanted to ask. Thank you.
Thank you, Danielle, for your conference. There are a few questions in the chat. The first one is, you use any formula to calculate the requirements of energy, or do you only use the 20 to 25 calories per kilo?
So we only use 20 to 25 calories per kilo. So at the moment, we don't do any indirect calorimetry because it is, I'm not sure it's worth it. I don't know that it's worth the time. So we do 20 to 25 calories per kilo.
Okay. How often do you use mixed nutrition and in what relation do you use?
So in terms of parenteral nutrition and enteral nutrition?
Yes.
So we tend to use mostly enteral nutrition. So about 90% of our patients will only have enteral nutrition, and that could be NG feeding, or it might be the post-pyloric feeding. We use parenteral nutrition in about 10%, but that would normally be parenteral nutrition on its own with maybe 10 mils an hour of enteral nutrition. Until we're building them up. We don't tend to use supplemental parenteral nutrition. It just tends to be that our patients don't necessarily need that. And I think it's because we place the NJ tubes or the post-pyloric feeding tubes quite early. So we don't tend to use PN and EN together. It would be one or the other normally.
Okay, thank you. One of the principal problems is the muscle wasting. Do you have any strategies to avoid it?
Yeah, so that's a really good question. So my whole PhD has been on exploring interventions to reduce muscle wasting in ICU patients. And at the moment, we really don't have any good strategies that will prevent it. So I would say what we need to try and make sure of at the moment is that we're meeting protein targets, so a minimum of 1.2 grams per kilo per day, and that there is some physical rehabilitation, because the patients will always lose muscle because they're not able to do any exercise. So I think what's important is early physical rehabilitation and meeting protein requirements. Again, we don't have the studies to show that that works yet, but I would think that they would be the two strategies that would most likely be of benefit at this point in time.
Okay, there is another question in the chat. They asking, what is the tube that you must use, nasogastric, postpyloric, or gastrostomy or jejunostomy?
Mostly NG, so nasogastric. We probably use NJ feeding in around, I would say around 20 to 30% of patients. So quite a number, but mostly nasogastric. And we've never placed a gastrostomy tube in an ECMO patient yet.
Okay. ¿Alguien quiere hacer alguna otra pregunta más por el chat? Well, we don't have any more questions.
Right.
Do you have any formula, enteral formula that you prefer?
So we, the company that we have a contract with is Nutrition. So we use all of the Nutrition products, but probably the ones we use the most would be the high protein products. So we always make sure that the patients start on a high protein product, and then they would continue that unless they have to have a fluid restriction. And we also use the protein supplements. So we use ProSource. I'm not sure if you have that available to you. It's a liquid sachet. And we also use that quite frequently if we need to. So that just gets bolus down the NG tube.
Now in the COVID patients, traditional, we use low carbs formula. You use them or no?
No, we don't use a low carb formula. Not as a general rule. Sometimes we've tried it if we've got patients who have very high CO2 levels and we can't get them down. We might try it, but I personally haven't seen that it's very effective. So we just use a standard high protein formula.
Okay, we have one question of Sebastián Contreras. They say many of these patients have high levels of vasoactive support that normally delay the start of the nutrition. How to compensate those periods of starving when you start the nutrition therapy?
So sorry, what they have high levels of
vasoactive support that may delay the start of the support.
Yeah.
How to compensate that period?
Yeah, so do you make up the feeding? So I think that's a difficult question as well, because if you miss out on feeding in those first few days, then it is very hard to catch up after that period of time. And I don't think it's very safe to overfeed too much. So we do always try and give a little bit extra, maybe 10% extra in the days afterwards, but we don't like to overfeed too much. So in order to get over that, we try and start as early as possible, because that helps to prevent those deficits occurring in the first place. So I think if you miss out the first few days, I think you could give maybe 10% extra, but I don't think it would be worth giving any more than that.
Okay. What day you say that we have to be in the target of energy apport?
So I would say if you can start some sort of feeding, any feeding, within 48 hours, and if you can get to a minimum of 80% by day 4, I think you're doing pretty well. It normally takes us around 4 days to get to 80% or above. So I think if you can get to that level, you're doing pretty well.
Okay. When you use parenteral nutrition, you use central catheters, or you may use peripheral insertion central catheters?
We only use central, so we don't do any peripheral nutrition in our ICU. I know some intensive care units in the United Kingdom do use peripheral, but we don't in our unit. We only use central.
Okay. Well, I don't have any more questions.
Excellent questions.
We are very glad to have you here. We appreciate your time.
My pleasure.
So very, very thank you. We are invite you to come here any time you want.
Love to. I would love to. Once we get rid of COVID.
Yeah, it's a good idea.
Lovely. Thank you so much for having me.
We are working on try to publicate our experience with those patients. We are starting with create the protocol, and well, I show you the results.
I really look forward to that. Thank you so much. That's great. And okay. If anyone wants to email me with any questions after today, I'm very happy to take any emails.
Okay.
Great. Thank you so much.
Bueno, muchísimas gracias a todos por unirse. Nuevamente le agradecemos a los participantes por su asistencia y a ABOT por el apoyo en el desarrollo de esta conferencia. Hasta una próxima oportunidad. Que estén muy bien.
Muchas gracias a todos por su participación.